Hello, and welcome to another live weekly session. This one is falling on a holiday and during the lunch period. And you would think that would give me more time to be prepared, but of course, it never does. And so here we are. I'm going to be doing a lot of talking over some of these slides because it's a holiday week. We've just been kind of all chilling. And so maybe we can just kind of come together on that note. So today we are talking about etiology and risk factors for oral myofunctional disorders. If you were unfamiliar with the term oral myofunctional disorders, don't worry, we will discuss that during today's live. But the etiology and risk factors are incredibly important, especially for dental professionals. Now, everybody should really be aware of these, and it's not just for dental professionals, but overall, I think it is incredibly important. And a lot of what I talk about is geared towards dental professionals because we are the people seeing this more often than any other professional. And that I will happily debate anybody on. Okay. So now getting into everything, I want you to just kind of silently think to yourself if you've ever had this kind of patient in your chair, okay? Someone who is gaggy, someone who, right away you see their name in your schedule and you just know it's not going to be great today. Today is going to be a mess because they gag almost every time. I know I probably won't get x-rays. This is the person who refuses and we're going to struggle. I've definitely had a lot of those, right? The anxious patient who gets in the chair, probably most likely they're the one who comes in right away and reveals themselves immediately by sitting down and saying, I really hate the dentist. I don't like being here. Great. Well, I didn't make this appointment for you. I don't understand why we have to start out like that, but it would be nice if they would just introduce themselves. It's like, hi, I'm so and so, and I'm anxious, and I don't really know how to express that anxiety in a way that will, make this more pleasurable. Because just coming in and telling me that you hate me is not the way to go about it, right? So anxious. One who has crowded teeth. I know many of us have seen that. A lot of the population today has smaller arches and more crowding and more of that same experience. Hyperactivity. So they get in the chair, they're moving around, they can't really get themselves in a good spot. They're just gonna kind of move and stretch. Oh, and I need a break, and I need frequent breaks because if I don't have frequent breaks, I can't get myself coordinated, right? The tired patient, and it's wonderful and beautiful sometimes when they fall asleep and their mouth's wide open and you're just able to do whatever you have to do. They're not talking to you. You don't have to talk to them, which is the best part of my perspective. You don't have to talk to them, and we just kind of keep it pushing, right? They're tired, but they shouldn't be falling asleep like that. Not in your chair and not with their mouth agape. It works, but it's not good for them functionally or for restorative sleep, which is likely why they're falling asleep in the middle of the day during a dental appointment. For those of you who do pediatrics, and hopefully not those of you who don't, who see adults only, and hopefully you haven't seen them with their thumb or with a pacifier in their mouth occasionally. Never say never. I wouldn't doubt that maybe that has happened. So you've seen them come in and there is something in the way of your work area. This is my workspace. Do not come into my workplace with something in my workspace. That's just not the way that's going to work. And a lot of what we will talk about later when we get into the etiology of oral myofunctional disorders is the impact that we know that a thumb or a pacifier has as dental professionals, right? So we'll turn that into how that translates to oral myofunctional disorders in just a second. Or mouth breathing. A lot of times their mouth is open, you're in there, you're doing what you got to do, and all you want to do is be able to see because you have this mouth mirror that should be a reflective surface. But when there is a bunch of hot air on it, it fogs up. And that fogging up is not pleasant. Okay, the fogging up is the part where you're breathe through your nose, and sometimes they're I can't, I don't know how, or my mouth is open, I can only breathe through my nose with my mouth closed. That's not true. It's not true in any capacity. Okay, so think to yourself, have you ever had this patient in your chair? I'm sure many of you have. And, I can think of multiple people that apply to many of these and probably are multiple of them in the same sense. Well, they all have something in common. Can anybody guess what that one thing is? I'm sure because this is about oral myofunctional disorders, you're going to assume that they all have oral myofunctional disorders. And yes, actually, some of those things are an oral myofunctional disorder, but they all have a need for myofunctional therapy. Okay. Now, why would they all have a need for myofunctional therapy? Like, myofunctional therapy can't be for all things. And I will never tell you that it is. But what I will tell you is that you miss oral myofunctional disorders every single day. Here is a fun little way to kind of connect the dots on that concept. Okay. So we're just going to watch the
This
video.
is an awareness test. How many passes does the team in white make?
Go!
The answer is 13.
Anybody got that right?
But did you see the moonwalking bear?
I bet you didn't. So watch.
Go!
It's very easy to miss something that you're not looking for. Now, while this was an ad to look out for motorcyclists, it is something that I think is super relevant for us and what we do, because as dental professionals, you have goals, you have things that you're trying to check off. None of us, I mean, if I was to ask who has extra time here at the end of every patient, more often than not, you're running behind, like we're struggling, or if we're not just keeping directly on time, right? It's kind of like our days are Where's Waldo? You're looking and you have to find all of this stuff. You need to do an oral cancer screening, you need to do their oral health, you need to go over their oral hygiene, you're going to have to actually do your clinical task, x-rays and so forth. Like, you have to get all this stuff done. And finding that oral myofunctional disorder is like trying to find Waldo in the picture. It's just not something you're looking for. And so you might miss it while you'll see a bunch of things around it. And you might see things that might culminate to that. There are a lot of people who struggle with oral myofunctional disorders that you may miss every single day because you're looking for something that ideally would be a greater thing that, in your perspective, you have to do as part of your duties. So, when we're thinking about those people who like to dig deeper and to find Waldo, Alfred Roger, just going back to the history of myofunctional therapy, I love this slide. I love the idea of talking about where it came from, because it was that desire to look deeper, to dig deeper, and to figure out why something is happening. So a lot of times we don't really have good explanations. And there's nothing that is more frustrating for a patient or for another provider than when you don't know the answer to something and you kind of just babble off some nonsense, right? So let's say there's a parent coming in with a child and the parent's like, I never had braces. I don't understand why my child needs one. Well, oh, we don't know what, dad's teeth look like or mom's teeth look like. And, when they two come together, genetics, dad's big teeth and mom's small mouth, now we got crowding and yada, yada. That doesn't really make sense. It just doesn't. It sounds nice, but it doesn't sound scientific in any way, shape, or form. Genetics, we know to be 100% true, is really like rolling dice, okay? And the body is not going to intentionally produce a bunch of different defects that would intentionally crowd an oral cavity. I mean, then there should be a bunch of other things going wrong. Now, while there are issues that will occur, there are genetic defects and there are genetic sequencing that can impact, so that you'll have macroglossia, so that you'll have elongated growth, and like your joints will have stretched out growth periods. And so you probably will need to have some sort of surgical intervention at some point. Like there's a lot of different things that can actually relate to that. But Alfred Rogers was a doctor who studied under Edward Engel. We know Edward Engel to be the father of malocclusion. Some people consider him the modern father of orthodontics because orthodontics is all about where do we get everybody's teeth in place, right? Let's get everybody to class 1. So how do we get to class 1? Occlusion. Yeah. But Edward Engel himself was curious, as was Alfred Rogers, but Alfred Rogers, it was like an alley-oop where Edward Engel kind of threw up the ball. Alfred Rogers slam dunked it, made that score, and said, why is it that people have malocclusion? Like, this doesn't even make sense. There is no world in where all these people should be coming out so varied and different. So how can we look at anthropology and studies of what influences bone growth and get to a point where we understand why that's happening? Okay. So Alfred Rogers, by the time he had hit 1920, yes, I'm talking about like 100 years ago. So myofunctional therapy isn't as new as some people think that it is. But by the time he had hit 1920, he had over 50 published articles on muscle training and the influence of soft tissue pressure on the bone, which makes so much sense in science in one regard, and then we have to add on another regard so that we can get to this etiology, okay? So that first regard is that everybody kind of understands form follows function, but when form follows function was put out there, it was for architecture. It was not for medicine, healthcare, dentistry. Nothing that had to do with the body. It had to do with artificial structures in architecture. The form is going to follow the function of the building, right? So how is the building going to be utilized? We have to build to that. It makes sense there. And that's why I like this quote by Frank Lloyd Wright, because that's a complete misunderstanding. We now interpret it to mean whatever we want it to mean. When in reality, when we're dealing with organic beings, right? We're not dealing with artificially built and produced buildings and structures. Form and function are kind of synergistic. They work together, right? So our soft tissue pressures have to kind of work with how the function is going in order to help to shape the form, because the form is not just going to willy-nilly just follow whatever. I'm sure you all may have been familiar with somebody who you're like, oh, you're tongue-tied. You must be struggling with such and such, such and such, such and such, because there's like this expectation. If we see ankyloglossia, you should have speech issues. You should have digestive issues. You should have dental crowding. You should have this list of things that are supposed to come because your function's impaired, so your form must be altered in some way. And that's not always the case. That's not every single thing, which is why I always say, like, tongue ties is not something that should be generalized and we should be telling everybody to start looking for, because you can look for and identify ankyloglossia, absolutely. But when you look for and identify ankyloglossia, what are you looking at? The structure? You're just looking at the form? Well, what's the function and what's the dysfunction that's associated? You have to look at them as a junction. They should be together. And so these two things have to coordinate in order to be true. And a lot of times, referenced also is Wolff's Law, which is absolutely applicable. And it's all about joints, more so than anything else. It's a lot about joints if you go and you read into Wolff's Law. But Wolff's Law, I've heard more in this last year than I've heard about it ever in my life, including in university studies and whatever. And to sum it down in its most narrow definition, it's that bone is going to adapt to the loads of which is placed on it. But Wolff's Law is problematic within healthcare And it's not even something that's widely accepted because certain variants of it have been proven to be untrue, or that the body will react without any load being put on it, that bone will adapt just naturally. Which kind of leads me to where I feel everybody's confused. And honestly, you should be confused, because if it's not about the soft tissue pressures or the bone or the structure, like what is it all about? It's about really this concept of epigenetics. Epigenetics is the real winner here. So, epigenetics is going to put nature, nurture, genetics, all of your functional implications, all of the external environmental factors that you have no control over. And it's going to put them together for how those soft tissues will now function. And then in turn, how the bones around that will react and adapt. Okay. So I know it's a lot. Tell me if at any point in time you're losing me, or if it is something that you're following along well with. Okay, just stop me at any time. I will go back, because I know you're hearing about this from very prominent names. You're hearing Wolff's Law, you're hearing form follows function, you're hearing this, that, and the other. You may have even heard it from me, not Wolff's Law, but the form follows function thing, particularly on social media. I want to challenge you. And what I love about doing these lives every week is that I have to continue to be a student of what I practice. And so I'm learning more each week. And as I learn more, I can share more. But I encourage you all to be students of what it is that you do, so that you can really, truly, and deeply understand what's going on with your patients. Okay. So moving forward, all right. Yes, body responds to forces. We know that because a lot of TMD, and I hate it when people say TMJ, because that's just the joint. Like everybody has one. Like, I have TMJ. Yeah, I do too. What's your point? But that's neither here nor there. The TMD, when they have TMD, particularly with disc displacement, and for those of you who were with me a couple of weeks ago when we talked about TMJ and its relevation and its relevancy, with oral myofunctional therapy, a lot of it is that when we have retractive forces or retrusive forces on the mandible, it's going to change the location of the condyle. That is going to now alter the appearance of it, because osteoclast will start coming in and breaking down the bone. That way it can sit in the joint. And then we're going to have that disc that's going to now be displaced, and oral myofunctional therapy or functional work is going to help to rework to build a new pseudo disc. Okay. We understand that the body is going to respond to force in a multitude of ways. Like with this first picture, it is forward head posture. Very obvious, very overt forward head posture that I don't think I see in that capacity from a lot of people nowadays. We do see it, but it's hardly ever like that bad. But when you have that forward head posture, it's going to place an inferior, so it's going to bring your jaw down, an inferior and posterior, so back, so your jaw will come down and back, and that mandible being down and back now displaces where that jaw temporomandibular joint sits. So that condyle won't be able to sit appropriately in the condyle, in the fossa. The condyle won't be able to sit appropriately in the fossa. When it's not sitting appropriately in the fossa, now we're going to have undue forces that are going to break down the bone. When we're talking about oral myofunctional disorders, though, we're hardly, if ever, talking about breaking down bone, with the exception of this talk of a joint. Wolff's Law, its application for joints, myofunctional therapy, its application for joints, makes sense when we're talking about the temporomandibular joint. But we're never talking about breaking down the body or breaking down the bones when we're talking about myofunctional therapy. And that was never the intent that Alfred Rogers had for us to interpret it as, and so forth, with the form follows function. It was more so that the soft tissue pressures of your lips and your cheeks as the external forces, when balanced with the soft tissue pressures of your tongue as an internal force is going to influence the position and the shape of the craniofacial structures they surround. That makes sense. It's not a breaking down of bone. It's not placing an undue force. It's just a different force. It's a pressurized force, right? So when you change the pressure, now you're going to alter what's happening and occurring. If I am trying to grow in a pressurized situation, I'm going to struggle. I'm working against all that's around me. If I'm a uterus, I'm working, not a uterus, if I'm a uterus, oh my gosh, if I'm an embryo, I'm working against all the pressure that's around me. It has to be balanced in a way that allows me to grow. Otherwise, in combating all this pressure, we might have a situation where now it can't be as viable because I cannot grow in this altered environment, or certain aspects will be altered because of undue pressures. So when you have falls and things like that during a pregnancy, when you have things that are going to impact directly the environment of which that embryo is sitting, this growing body is sitting, now you're going to have these undue forces create new pressures and new stresses and strains. So when we're stressed and strain the craniofacial structures, the skeletal bones, that's when we're going to find that we have malocclusions. Malocclusions are going to lead, it's like this sequelae or like a domino effect. It's like a sequelae of events that are going to now impact what's going on with us in our oral facial development and our dentition, right? So I love this slide. I used to say that I find a way to put this slide in absolutely everything, and y'all have had so many weeks where I have not put this slide in anything. So now I'm lying when I say that. But it's always exciting and refreshing to go back to where your tongue rests matters, because your tongue resting posture, in addition to the lips and the cheeks at rest. So people who suck in the cheeks a lot, who are biting on their cheeks and pulling in, you're creating an external pressure that I don't care where your tongue is resting, it's going to have an impact on the teeth. It's going to have an impact on your bone, your alveolar bone. It's going to have an impact on those teeth and the periodontal health on that side. It's going to have an impact. These pressures have to be balanced, right? So where your tongue rests matters, how your lips rest matters, how your cheeks rest matter, where your jaw rests matters. Okay, it's really all of it. It all matters because these are counter pressures that are going to flow with each other. I am not seeing anything pop up in the chat, so I'm really excited about that. That means everybody's with me and nobody's getting lost. Awesome. Okay, tongue lightly suctioned up at rest. We want that tongue lightly suctioned up against the palate from the incisive papilla all the way back to the soft palate. You should be able to feel your tongue at rest sitting up there. How do you know where your tongue is at rest? Feet flat on the ground. Sit up nice and tall if you're sitting. If you're standing and you're listening to me, if you're driving, don't do any of this. If you're standing and you're sitting listening to me, I want you to stand up, good posture as best you can. Take a deep breath in through your nose. We're going to take a deep inhale through the nose. Then I want you to exhale through your nose. Inhale again through the nose. Exhale again. And I want you to do that 3 more times. As you are doing it, I call this my 1-minute breath test. I want you to, if you have to, close your eyes. If you're driving, don't do it. If you can, close your eyes. And I want you to just really be aware of where your tongue, your jaws, and your lips are as you do this. Now, there are times where I do this and you're sitting with a client or a patient, and as they're breathing in for the first 1 or 2, as soon as they start to get introspective and they try to see what's going on in their body, lips will part, and that's their real lip posture. Okay, their tongue might drop. Like as soon as they now have to concentrate on what's going on, things kind of change back to normal. So they might still be inspiring and expiring through their nose, but the lips are open, like they have open mouth resting posture, or they're unable to close their lips, but they can respirate through their nose, or they're unable to breathe through their nose at all, or they're just unable to really feel where the tongue is, but they know that their teeth are together. So now they're feeling the bracing of those teeth and not necessarily what's going on with the soft tissues, because the hard tissues are actively engaged. And while they are engaged, they're engaging some of the external soft tissues. And now that's creating a negative external force that can't really balance out what's going on internally, because that tongue really just can't perceive where it is in space or time. Okay. Where the tongue rests matters, because you need your tongue to be lightly suctioned out. You want your teeth to be slightly apart. Your teeth should not be together at rest. That jaw posture matters, because as you place your mandible more inferiorly, so too much of a space in between the teeth, more inferiorly, so more downward, that mandible is shifting, that's displacing the condyle. Okay, that jaw posture matters a lot for your patients who have temporomandibular joint disorders. That jaw posture changes, and now we have our tongue sitting in an improper place more likely than not. And if the lips are open, well, now we have just ample space that the teeth are not restrained in any way, shape, or form, and can now do a flaring of sorts. So when you see anterior flaring of teeth, I call that proclination. Some people just call it flaring. I think the correct term is actually, anterior proclination of teeth. Sometimes you're going to see more posterior retroclination, so that incline of the teeth. Everything is just trying to kind of brace itself. This progressive crowding, I want you to just note that these teeth are all inclined, right? So sometimes you'll find that the teeth are all kind of tipped a little bit in instead of facing straight in the way that they're supposed to. They're more looking and leaning towards each other. Okay, where your tongue rests matters, where your jaw rests matters, where your lips rest matter. It all matters, okay? In the greater scheme of, we're dealing with this as a sequence that develops as a direct result of epigenetics. Epigenetics is a fantastic study, and the more I study it for a number of different things, one, genetics, we know, complete dice roll. Complete dice roll. You have people who are full siblings and look absolutely nothing alike. There are no real studies that can define down genetics to predetermine what's going to happen. What we do know about it is that all the external factors do have an influence that can rewrite or remodel how our DNA is expressed, or sometimes sequenced. Like our sequence, for the most part, studying the human genome is a big, big project, and it's taken hundreds of scientists and lots of years just to break down the DNA sequence. But it can be altered by just an external factor coming into play. So our oral function and our soft tissue pressures, and how those directly influence each other based on what's presented already by genetics. So genetics is already there. That's our foundation. This is our first Lego block. We're going to build a house. Next, we've got our soft tissue pressures. That's going to impact what's going on with our next Lego, which is our oral function. And that oral function is going to have a direct relationship to our next level, which is how our craniofacial structure is developing as a result. Okay, don't lose me in any way, shape, or form. All right, here's what's involved on a small scale, because there's a number of different things that are not addressed here. Nature, nurture, and how they combine. Okay, so nature, there's a number of things that aren't even here, such as socioeconomic factors. If you don't have access to good health care, to good water, to good food, to natural whole foods. If you're brought up in an environment that is feeding you a lot of processed foods or giving you a lot of mush and squish and soft foods and nothing that is healthy, that's going to create a problem. But sometimes that's a combination that I've really just grabbed something from nurture, the foods. But the socioeconomic factor is your inability to be able to access more. We're born into a lot of that. Sometimes your socioeconomic status does not change until you are the person in your family able to do so, until you can get yourself into the next tax bracket or the next socioeconomic status level. So there are things here that are not addressed. Don't think this is a comprehensive list, but this is definitely a lot of different factors that influence what's going to happen when we are trying to look at how our craniofacial structures are coming together, where will we develop oral dysfunction, and how that will manifest into an oral myofunctional disorder. Okay, just keeping you all with me. I'm so glad there's no questions in the chat. Okay, nature, genetics, pregnancy, birth. Pregnancy is, again, another kind of dice throw. These dice throws, if there's any sort of undue stress, if there is trauma during the pregnancy, falls, accidents, things like that, if there's any issues with the pregnancy and how everything is really coming along. So sometimes there are in utero surgeries that need to be done. There are things that are influencing the pregnancy itself and the pressures and the environment upon which you're able to grow. That's going to be a problem that will impact how you develop and furthermore, how you will function later on. Birth, we know to be a traumatic event, period, and all for that. Birth is something that you come down the birth canal and you're squeezed, you're squished, your craniofacial structure is altered. And that's why a lot of those sutures are not merged, because as you come through the canal, we need to get that squish happening, right? But then some of the pressures that are put on as you are coming out, that's a thing. Now, never, ever, ever would we hold a baby, a newborn, particularly by its head. But interestingly enough, as you're coming out of the birth canal, whether you're coming out vaginally or you're coming out via cesarean section, you are often grabbed right by the head and the neck, right? Like the fingers are around the neck. And this is something that's so common. We don't even think about it. We don't even process it beyond the fact that it happens. You're grabbed by your head and turned or twisted or manipulated by your head first. Yes, that's part of the design, right? Giving birth, you're guided by your head, yes. But outside of that, we would never, because you don't want to have undue influence on your newborn's head, not on their head shape, not on the brain, not on the cranial structures. Like, you don't want to. You know that if you leave them sleeping in one position for too long, like if they're sleeping and they're on their back all the time, sometimes you get that flat head in the back. Like, we know those heads are malleable. We would never grab a baby by its head. Birth is the wonderful traumatic exception where it's totally okay to just kind of manipulate and do what you want and do what you can, because we got to get you out into the world. Absolutely. We're not going to leave you stuck in the birth canal. Sometimes there are babies who get stuck in the birth canal. Now you have the undue pressures of forceps with a pulling force, right? So now we're creating force on the spine, directly on the spine of a newborn. It's something that will, and I don't want to spend too much time on this slide because I know I tend to ramble on this slide. I'm sorry, and I apologize for that. But birth and its subsequent effects can have a negative impact on your craniofacial structures. That's essentially where I was going with that. Tethered oral tissues, we know that's in utero. You're not born and your tongue is wonderful and free, and then suddenly now the frenum decides it's going to be restrictive and then it just shortens. That's not what happens. You're born with it, right? So were you born with limited range and limited mobility? How will that impact craniofacial development? Will it impact craniofacial development? Always ask yourself that. Weak muscle tone is a thing. There is nothing that grinds my gears more than myofunctional therapists talking about tone and muscle tone and how we work with muscle tone and the oral facial. No, hypotonia is a very real thing. There are people who are born with low muscle tone. People have very big struggles trying to overcome gross motor skill delays, gross motor skills inability because of their poor muscle tone. We don't work on muscle tone. We don't in any way, shape, or form. We work musculature and function and so forth. And we might help to heighten the awareness of these regions. We might help to heighten the functional use of some of these muscles, but we're not working on the tone of the muscle itself. Save that for the people who have degrees in hypotonia, the people who are registered and that's in their wheelhouse. So whether it's a physical therapist or an occupational therapist, save all that for them. But nurture muscle tone, whether you're born with that delay or something, that is out of your control. Observed and learned habits is always an interesting one to talk about and to share because observed and learned habits are going to occur directly as you are growing. So you're learning, you're living, you're observing what's going on with your parents. If mom has a tongue thrust and dad has an open mouth, what do I think is normal? Open mouth breathing. Dad breathes like that all the time, and a tongue thrust. So anytime that I'm using my tongue for an L, a T, a D, an N sound, or whatever sound mom has an error on, guess what I think is normal? And I start putting into my, brain, my habit, because I want to be just like mom or dad or whoever is raising me. I want to be just like them. So now I'm going to start doing that, right? If they're not eating great foods or they're eating their foods inappropriately, they bring a spoon to their mouth and the tongue comes out, licks everything off the spoon. That's going to be how I now am going to use my tongue when I'm eating. It's not going to be the way that nature may have initially intended, but I have no control over that. I'm seeing that when I'm unable to make a better choice for myself or know that there are other options. Environment, climate, allergies, socioeconomic status, your genetics as far as any sort of religious or cultural or racial factors that play in. All of these are going to play a role in a number of ways. Again, I don't want to spend too long on this slide. Breastfeeding, bottle feeding, we know that there's a very distinct difference. Okay, you have no control over how you're fed, but that nurture aspect of it, the fact that it is happening and it's happening multiple times a day, every day, that's something that there is an effect to. Fed is always best. Absolutely, you want to be fed. You may not even been bottle or breastfed. Maybe you were tube fed. Like you may have just wound up on a tube. All of that is going to impact how your tongue is going to function, how your cheeks are going to function, how your lips are going to function, because they didn't get to function in the way that others would have gotten to function if they were breast or bottle fed and you were tube fed. So it all makes a difference. There is no functional use for a sippy cup. Absolutely none in any way, shape, or form. There's no reason for a sippy cup outside of to prevent spills for parents. That's it. Functionally, you should be able to go from breast or bottle to open cup or straw. Okay. It's just you're going to make a lot of spills along the way because you're 12 months old. You're going to spill, right? That's like trying to prevent poopy diapers. It's going to happen. So we just kind of have to accept all of that. Sippy cups just don't have a functional purpose. Pacifier. Pacifiers do have a functional purpose. They need to be taken away. And the problem is that a lot of parents have a hard time taking it away and they use the children as an excuse. And I will say happily that I was one of those parents who'd be like, no, they need this. Like, it's fine. I'll just take it away from them when they're like 2 or 3 or whenever I feel like they can handle it. It's really me. I couldn't handle it. Okay. And honestly, it's the other parents too. Y'all can't handle it. You can't handle the fact that the kid is going to cry and you won't let them cry it out, or you won't let them try to find more positive ways to kind of repurpose this habit. So there are better ways and better things we can. Thumb sucking. I think we all know, in the same way that I'm telling you your tongue can create a pressure that will help to develop your palate and help to develop your craniofacial structures. If you've got a thumb or a pacifier in there, a lot of times people are like, oh, I could see where my thumb was sitting while I was thumb sucking, years ago. It does alter the shape. It is that adverse pressure, right? That soft tissue pressure that's creating a change when this function is happening. Chewing habits or lack thereof, absolutely going to create an issue. Mouth breathing, just the fact that the mouth is open, the jaw is posteriorly displaced. Now you've got your jaw's too wide. You're creating temporomandibular joint disorder issues. You're allowing more space for proclination of the teeth. Your tongue is definitely not sitting where it's supposed to. You're going to put yourself at a greater risk. Diet and allergies, and any combination of how these things cross each other. So you could probably do lines across to each of your issues that you think you have, right? So I believe I was a C-section baby. I know that for a fact. I was a C-section baby. I was breastfed for a little bit, but I think I didn't take too well to it. So it was, a bunch of my genetics, because both of my brothers had braces. I never had braces. I have all 32 teeth. Class 1 occlusion, ideal occlusion. I have perfect occlusion with no history of orthodontics. I did have a pacifier for a prolonged amount of time. There's a good story, and I'll share it one day, about how I think I got to where I am. But I did have a pacifier for a long period of time, and I was bottle fed. And I do like a lot of, I was a picky eater, and I have a lot of softer foods that I liked and so forth. And then there's the observed habits, because my parents have their own issues that I had to kind of work my way past and through. But how these interact are going to determine where your tongue rests, where your lips rest, how your jaw rests, and how your cheeks rest. Okay. We know this to be true because of this 1981 study, and all of that on that one slide was just to get to this one slide. We know this to be true because of this 1981 study on rhesus monkeys. So rhesus monkeys are this beautiful monkeys up in the top pictures. This is what they look like naturally. In 1981, there was this study that is equal parts wonderful and absolutely horrendous. And, I don't like it, but I like it because it definitely demonstrates what we need it to demonstrate. What happened is they took these baby rhesus monkeys, they plugged their noses. That way, monkeys are obligate nasal breathers. They plugged their noses so that they would have to be obligate mouth breathers. The body has one job: keep my person, keep my monkey, keep my whatever alive. Body has one key directive. Okay. So nose is blocked. Great. Fine. We're going to breathe through the mouth. We're going to breathe through the mouth. They were breathing through their mouth, and guess what happens? They develop low forward tongue posture, malocclusion. Monkeys don't have malocclusion. When have you seen a monkey with braces? That doesn't happen in nature, right? They're obligate nasal breathers. You now block them, so now they have to open their mouths, and they're having all of these issues. They can't maintain their airway, not through their nostrils, and their nostrils change. They don't develop the same. Their faces start to look different. It's an entirely different monkey. It doesn't look at all like how it should look. And then it's all of the health things that kind of subsequently, followed after. But this is a wonderful example using one of our primate cousins in how this is impactful and where oral myofunctional disorders really kind of stem from. So that etiology, that's going to be a blend of epigenetics, is incredibly important. Okay. All of that dysfunction is going to lead you to oral myofunctional disorders, which is an inability to utilize proper oral or facial muscle functions. That's characterized by overdeveloped muscles or underdeveloped muscles. So you're either overusing muscles or underusing them when you're breathing, chewing, or swallowing. Okay. Now, an oral myofunctional disorder is like an umbrella term. There's so many things that can be an oral myofunctional disorder. Unilateral mastication, Absolutely. You're going to have overdevelopment on one side, underutilization on an entirely different side. That might lead to a bunch of temporomandibular joint dysfunction, some lip incompetence. You're chewing on one side. Who's to say you're chewing with your mouth closed on that side? What's the tongue doing while you're chewing? Tight musculature, parafunctional habits. Like, you're getting all of these little things. Parafunctional habits. I think I've asked at some other live, and I typically ask when I'm doing live lectures as well for people to name me a few parafunctional habits. Let me tell you, mouth breathing is a parafunctional habit, clenching, grinding is a parafunctional habit, cheek biting, lip biting, tongue sucking, all of that parafunctional habits. So you're going to see it manifest as a umbrella of different things. Everybody doesn't get the same thing. Some people only have one little way that you can see that they have oral myofunctional disorders, and other people have like a whole gamut of things. And you're like, what happened to you? Like, that you wound up with all the symptoms and somebody else wound up with just this one little thing. There's health impacts that can be a direct result of having an oral myofunctional disorder, okay? Such as various speech issues, lisp, that forward tongue thrust in speech, articulation problems, gastrointestinal issues, sleep breathing disorders, obstructive sleep apnea as an umbrella term of things. And obstructive sleep apnea can be any number of things. Upper airway resistance syndrome is no longer recognized, and it hasn't been for some time. I love that our field is the only one that still talks about it like it's a thing. But the American Academy of Sleep Medicine has dismissed upper airway resistance syndrome for quite some time now. They don't even diagnose it anymore. It's considered a mild form of obstructive sleep apnea. But that's neither here nor there. But what's going to happen is that this umbrella set of terms for sleep breathing disorders is going to create non-restorative sleep, which is going to now impact your daily function. Psychological disorders, the first thing they tell you to do when you have anxiety, they give you breathing exercises, right? We know that breathing and how we breathe is very much related to anxiety and the expression of such and the management and control of such. Depression also has a great correlation with poor breathing. And then oral facial pain, which we know is always an issue. Okay, so with the last few minutes I have here, let me give you some clinical signs. Like, how are you seeing this? How does it manifest in your patients? How are you seeing this clinically? And how can you then now make the next step, which is going to be, putting in a referral, or you actually working with them. So extraoral clinical signs that you will see: allergic shiners. So allergic shiners, or also known as venous pooling, because there is a depth of the infraorbital space there that is not as much developed because of a lack of midface. So we should have equal facial thirds. And if that midface is not properly developed, you'll see a lot of times you'll get the depth under the eyes. So that allergic shiner is what it's called. These allergic shiners or venous pooling are, one, that depth of the space, but then blood pools in there, the capillaries and the blood, it pools in that space. And so you're going to see more darkness, people more pigmentation. It looks more purple, sometimes black in that spot. People with less pigmentation, it's more of like a pink. Sometimes it can be like a light purple, but a pinkish red, light purple. The classic allergic salute. This allergic salute, more like, you see those kids that are constantly, they're wiping their nose all the time. You see that they're going to create a crease on that nose, and you'll very distinctly be able to see that when you have your patient sitting in your chair. Open mouth posture, low tongue. You can see the freeway space that we want. So where we want your jaw to ideally rest is to have 2 to 3 millimeters of space in between the arches. So 2 to 3 millimeters. I want you to think about your perioprobe, dental professionals. When you're looking 2 to 3 millimeters, how big is that on a perioprobe? It's often negligible. This person resting with their mouth open like this, how inferior and posteriorly displaced is this mandible. What do you think that temporomandibular joint function looks like? Not great, right? Yeah. So we want to have better rest posture. Our lips to be closed, our teeth to be just ever so slightly apart, our tongue to be up. Everything about this is wrong. You'll see them waiting in the waiting room like this. Sometimes as you're waiting for an exam, as a dental hygienist, as you're waiting for an exam, you'll be talking to them, and in between time when they're not talking or they're just listening to you talk, that's when you'll really see their oral rest posture. Strain mentalis, not a huge fan of using this as like a sign. Some people just clench this. I think that this is a great sign when you're working intraorally. So yes, you can see the dimpling in it if you are looking at them extraorally. However, when you are in the mouth and you're trying to look at 23 through 26, you're trying to look at just a couple of teeth. You can't get there because this lip, you're like fighting for your life to be able to retract it. It's so overactive. That's going to be a big sign for you. So I think it's something you can more feel with your tactile perception as opposed to really looking externally. Sometimes you'll see it, sometimes you won't. Sometimes people are using it during a swallow, so you'll be like, oh, I thought I saw it, but I didn't see it. You probably saw it as they were swallowing. It contracted and then it relaxed. Gummy smile, vertical maxillary excess. Vertical maxillary excess. Yes. Gummy smile is always a big thing as well. You could tell this mandible is retrusive because just look, like there's no way it, like her teeth are so far out from her lip. There's no way that man. But a open bite as well is going to be a big thing and a big telltale sign there that you'll be able to see. That's most of our adverse pressures with our tongue and where our tongue is sitting, and our lips and where our lips are sitting. And then the growth, that excess growth, that long bony growth, is going to be a direct result of an oral myofunctional disorder. So you could really see it when you don't have those equal facial thirds, because that's that mid-face excessive growth downward. Intraorally, you're going to see it if you have asymmetric occlusion. So asymmetric occlusion is always interesting, because why would you be class 1 on one side and class 3 on another? Like, why would it develop differently? What is being changed between one side and another that your right and left don't have the same occlusion? It just really doesn't even make sense to me, right? It is definitely a big sign. Orthodontic relapse. Orthodontic relapse is a very big thing that happens a lot more often than we like it to. We don't want retainers to be the only way that you're able to retain your teeth in one neutral position. We really would like for the soft tissue pressures, intraorally and extraorally, to be balanced enough that that can help to keep everything in one place. We want to create a homeostatic environment for those teeth upon which they can live in. Okay. Clinically, you can also look at tongue thrust. I like to just spray a little water, retract the cheeks, tell them to close and swallow. Sometimes they can't do it. They can't do it. You're retracting their cheeks. You're getting all this stuff with their lips, their face. They're trying to, and they just can't do it. Narrow dental arches, for obvious reasons. A high vaulted palate, that tongue is not sitting up there. If it cannot sit up there, it's going to struggle. And so that high vaulted palate, it's not a place where our tongue is able to rest appropriately. Asymmetric malocclusion, I already touched on the Shriners. The flaccid cheeks is such a big thing for me because I love the kids. I love working with kids, but it's so obvious. A kid over the age of 3 that has these cheeks that you just want to, oh my gosh, you've got the cutest, most chubby cheeks, and I just want to and love on you. Those cheeks, don't love on those cheeks, okay? Send them to myofunctional therapists so that we could work on it, because they, more often than not, are not swallowing appropriately. They're probably droolers. Like, we have issues there, okay? Flaccid cheeks, flaccid lower lip also. That Napoleon Dynamite appearance is going to be one of those big telltale signs. Bunched mentalis, that bunching or stippling strain mentalis. Audible breathing. Audible breathing. Breathing is always intended to be something that is inaudible. You should never hear anybody else breathing. What about snoring, Chris? Isn't that normal? No, snoring is not normal. Snoring is common. There is a difference. And if you're hearing them snore, snoring is really the sound of air meeting resistance. Audible breathing is the sound of air meeting resistance as it's going through your upper respiratory tract. Do I want air to meet resistance as it's going into my lungs? No, for no reason. There's not one reason I can think of where I'd be like, yeah, I want the air to kind of slow down a bit on its way to my lungs. No, I want to be able to respirate appropriately. Okay. Enlarged tonsils are also something that's big in talk, but we don't have a full grasp on the direct correlation there. So I keep it in because it's kind of like a acceptable thing in the field, but also it's definitely not. Okay, so you're looking at people, you're seeing some of these signs, maybe you even have some people in your mind, you're like, what do I do? You could take a look and stop and think about every single one of these things and start marking down things, but who has time for that? Brooms was a very simple screener that I created, co-created with another hygienist. It was created by hygienists for hygienists, okay? So the Broom screener is meant to take you seconds to be able to, one, fill out, but then two, determine what's going on. So the Broom screener has actually been published multiple times, RDH Magazine, Dental Sleep Practice, Spear Education. It's been posted multiple times. It's something that's been written about. It is legitimate. Okay. So the Brooms screening, we're going to go over Brooms and I promise I'm going to let you go. Brooms, 2 or more in the affirmative column needs a referral to myofunctional therapy. Okay. Do they brux? Yes or no? How long does it take you to determine if they're a bruxer? Seconds. We know easily. Can you hear them breathing? Yes or no? You don't even need to stop and like take time for that. You're working with them. Can you hear them breathing? Orally defensive. We know those orally defensive patients. You are just trying to do your work. All you're trying to do is work. And that tongue is like a curious tongue that's like pushing you all over the place. You feel like you're going to break your finger as you're just trying to retract a cheek or a lip. And it's just so tight. They are fighting for their airway. So they're being very defensive. They don't want too many things to be in the mouth. They cannot express that. It comes off as just a defensive system from the body. Okay. Is the open mouth, so we all know who those people are. I mean, before they even get there, some of those people you're like, yep. Right. Open mouth posture, is it yes or no? Maxillary transverse width, the maxilla, is it narrow or is it nice and big and broad? And do they have a strain mentalis, yes or no? So Brooms is going to be your wonderful sweeping generalization. If you need a copy of the Brooms screener, feel free to reach out to me at any point in time. I am more than happy to send it to you, okay? Let's talk really quickly about what you do after you've determined that they do have an oromyofunctional disorder or that, you think they are a big candidate for myofunctional therapy. I want you to Google myofunctional therapist near me. Okay, Google. I think that is the easiest way. People overcomplicate it. You send them to this directory or that directory. I don't like directories. I'm a part of directories, yes. I don't like directories because directories, more often than not, you have to pay to be a part of it. So it's a pay to play. It doesn't tell you anything about the quality of that therapist. It doesn't tell you how well educated, how long they've been doing it, whatever. It doesn't tell you any of that. It just tells you that they paid money for their name to be right here in this list with other names. Okay. And that's not always a bad thing. Sometimes it's professional associations. They're able to grow and learn and whatever as a part of. It's not just for the directory. But Google, any myofunctional therapist worth her weight in gold or his weight in gold is going to have a Google My Business page pop up. Now, even if that is 50 miles away from you, If that's your nearest myofunctional therapist, I would highly encourage you to reach out. They're going to tell you the best candidates for them to work with. They're going to be able to give you a lunch and learn, talk more to you about it. If you need a lunch and learn, I do virtual lunch and learns. I am more than happy to treat you guys to lunch and talk about it to your office and so forth. But you can find somebody near you, send them the referral, and they would be more than happy to talk to you. I haven't met a myofunctional therapist that doesn't like to talk about myofunctional therapy. So we're always happy to talk about it. We're always happy to kind of get it going. If you're struggling with implementing a screener such as brooms or whatever, just reach out. I'm happy to sit and like talk with you and really get it more well defined in your system of things that you have going on as you're already looking for 10, 20 other different things in the mouth. Okay. We've got salivary testing, we've got oral cancer screenings and tests, we've got all sorts of things going on in dentistry, intraoral scanning. We're doing a lot. I get it. So, with that, I'm going to let you go and enjoy the rest of your holiday weekend. Thank you so much for being with me today. I hope that you've learned a little bit of something. If you have any questions, never hesitate to reach out. And until next time, keep learning.